Dear colleagues, I'm very happy to be with you. Thank you very much for inviting me here with two talks. This one is related with the quality of vision. Here are my financial disclosures. None of them is relevant to this topic of this presentation. So, as we all know, modern cataract surgery is based on the small incision technique that minimizes induction of astigmatism, different types of monofocal IOLs, and some pseudo-accommodation solutions, including multifocal IOLs and monovision. We are quite aware that multifocal IOLs are based on the two main focal points at least, and that patients with more intermediate vision habits may have worse tolerance and longer time of adaptation to multifocal IOLs. And this technique is highly dependent on light. We also know that the mean light distortion index is significantly higher in multifocal IOLs than in monofocal lenses, and patients with corneal diseases with significant abnormalities in Schirmer tests, like moderate, mild dry eye syndrome, have higher risk of light distortion. So we should be quite cautious with patients with diabetes mellitus, rheumatic diseases, Schirmer syndrome, history of radiotherapy, etc. There are some challenges of multifocal IOLs. Some of them were already mentioned during this meeting yesterday. So there is a process of neuroadaptation. Visual acuity with multifocal IOLs tends to improve over time. Patient determination is a sort of an unmeasured factor of post-operative quality of life and vision. Then reasonable expectancy of visual acuity after operation is very important. That's why careful selection of patients is crucial. So, what are the methods of evaluating quality of life and vision? We have three generations of different questionnaires. The first generations, which try to evaluate difficulties in performing particular tasks, not differentiating the importance of certain tasks in patient's lifestyle. Then the second generation questionnaires, they involved rash analysis, item values, and these questionnaires are calibrated and person abilities are measured on a shared continuum. And then there is a third generation questionnaires, use item banking, creation of an item database intending to measure a predetermined set of constructs. Just shortly, because it's a long story, we could of course analyze each of these questionnaires, but just to give a general overview of this field, there are different purposes for different questionnaires. For example, there are some questionnaires to evaluate visual function, like, for example, functional assessment of visual tasks. It belongs to the first generation of questionnaires, and it includes questions regarding difficulties in near, intermediate, near distance, distant tasks, so on. Then another group, there are visual function tests, which were prepared to evaluate visual function in visually impaired persons. For example, National Eye Institute Visual Function Questionnaire also belongs to the first generation. Then questionnaires to evaluate visual function and impairment related to refractive errors here. Another group of National Eye Institute questionnaires, refractive error quality of life instrument. Another group of tests prepared to evaluate visual impairment caused by cataract and evaluation of cataract surgery outcomes. Here we see the tests we know. CAT-QUEST, prepared by Lundstrom and collaborators, 97, belongs to the second generation. CAT-QUEST 9SF, also belonging to the second generation, and visual function 14, 7, and other tests belonging to the same group. Then we have some tests trying to measure near visual function in patients with accommodating IOLs. We have near activity visual questionnaire belonging to the second category. Then tests attempting to evaluate spectacle independence after cataract surgery. Here we have two tests: patients-reported spectacle independence questionnaire and spectacle independence lens vision evaluation and repurchase. And finally, we have tests which were prepared to assess benefits that patients perceive from being free of glasses after multifocal IOL surgery. The test entitled Freedom from Glasses Value Scale. So a lot of them. The next group, the methods trying to evaluate quality of vision test, evaluation of photic phenomena, the test called Assessment of Photic Phenomena and Lens Defects, evaluation of pseudophakic positive and negative dysphotopsia, test entitled Pseudophakic Dysphotopsia Questionnaire, assessing problems in everyday visual tasks, near vision activity imitation. So a lot of different tests. So, but what we have, what we got from the evidence-based medicine about the quality of vision and life in multifocal IOLs versus monofocal IOLs, what kind of data coming from evidence-based medicine. So we can get information from Cochrane database systemic review, which was published in 2016. And one of the issues which were covered with this meta-analysis was dysphotopsia. And it was shown that visual phenomena were more prevalent, more troublesome in participants with multifocal IOLs compared with monofocals. More or less obvious to us. However, here we see the graphs taken from this Cochrane meta-analysis showing that blurs are much more frequent than in multifocal IOLs than in monofocals, and seeing luminous halos around observed objects was also significantly more frequent. Interestingly, the risk for halos was much higher, as you see here. For glare, it's not such a big risk. It's 1.4 risk ratio, and for halos risk ratio is 3.6. So it is much higher. Then there were 11 randomized controlled trials which tried to evaluate the dysphotopsia occurrence in these two different groups, and based on this 11 RCTs, we can say that we can confirm that multifocal IOLs were associated with significantly higher reports of halos than the monofocal control. It was also supported by case control studies which reported more severe or higher frequency of photopic phenomena associated with multifocal IOL, including halos and glare, greater degree of bother and limitation in driving toward oncoming headlights due to glare and halos, and photic phenomena were reported to disappear in patients with monofocal IOLs at higher rate over time. What about contrast sensitivity? It's not as clear. Even we usually believe that multifocal IOLs are related with the worse contrast sensitivity than monofocal IOLs. However, as we see at the data, it's not as clear. At first, studies were based on different methods, so this is very difficult to compare all of these studies. Then tested under varying lighting conditions. So pooled results of 4 trials did not reveal a significant difference in contrast sensitivity. There were 13 randomized controlled trials compared contrast sensitivity. Again, I need to underline that under varying luminance conditions and at different spatial frequencies, they shown a disadvantage for multifocal IOL under at least some conditions, and case control studies confirmed that. So they shown some advantage in contrast sensitivity with monofocal lenses. However, these strength of this evidence is not very big. As we see here, there were reports based on visual function questionnaires, some evidence of more favorable outcomes in the multifocal group. Size of the effect was small and uncertain due to wide confidence intervals, and there was inconsistency between studies. Pooled result may not be meaningful, or there is no difference between both groups. There were, this is regarding patient satisfaction. There were 13 randomized control studies analyzing patient satisfaction. They varied greatly in methods of measuring patient satisfaction or quality of life. Most studies found very high levels of overall satisfaction among both patients. Some studies reported some advantages with satisfaction or performance at near, particularly without glasses for multifocal IOLs. Case control studies were similar. This is also an interesting study which was prepared by Sunil Shah and collaborators, published in Journal of Refractive Surgery 2015. And as you see here, they compared monofocal group with multifocal group, quality of life, and they found the differences in the three terms of dependence on correction, expectations, and glare only. Of course, coming from this data, we are quite aware about disadvantages of multifocal IOLs. They include blurred and reduced intermediate vision, glare phenomena, which is related to the loss of image quality. Nearly 50% of patients reported symptoms of glare and halos. Up to 10% of patients reported that the glare and halos were debilitating, and a varying percentage of these patients required an IOL exchange to correct their symptoms. And as I mentioned, there is some data, not very strong, showing reduced contrast sensitivity. Of course, there is another way to manage presbyopia. It is monovision. I don't need to introduce it. There were some studies comparing multifocal IOLs with monovision. There were 2 randomized controlled trials, and they found no difference in contrast sensitivity or glare between 2 groups, but significantly more unwanted shadows in the multifocal group. About 30% of the monovision group achieved complete spectacle independence compared to more than 65% of the multifocal group. There was no significant difference in the spectacle dependence at distance, but the multifocal group reported less spectacle dependence at near. Visual function questionnaire did not differ for near vision, distance vision, or overall between 2 groups. Overall satisfaction was similar between both groups for multifocal and monovision. However, about 6%, and this there were 6 patients of the multifocal IOLs underwent IOL exchange, of which 5 exchange were due to patient dissatisfaction about image quality compared to no IOL exchange in monovision group. Case control studies shown that there were never wearing glasses, about 26% in the monovision versus 71% in the multifocal group. Regarding contrast sensitivity, there was significantly reduced in the multifocal group compared to the monovision group. Significantly more glare and halos were reported in the multifocal IOL patients. So, in the conclusion, multifocal IOLs, monofocal lenses, and monovision, they provide high levels of overall patient satisfaction. However, multifocal IOLs are related with the high rates of spectacle independence compared to monofocals and monovision, with dysphotopsias, decreased contrast sensitivity, and more likely to IOL exchange due to the dissatisfaction with image quality. So, and the another conclusion is that there is no university accepted and standard validated measure of patient satisfaction after cataract surgery. That's why it's very difficult to compare results coming from different studies. And I would like to, at the end, show you the information about our presbyopia club in Poland. It was founded last year. We had the first meeting in my home city in Poznań in November, and this year we organized the second meeting, and welcome all of you to join us to this meeting. It's a two-day meeting focused only on presbyopia. We have some... Oh, sorry. Please, yes.
Okay, thank you.
We have some confirmed speakers, including Ron Schacher, Clash Feinbaum, and Barbara Pieszczonek, who, as I remember, was also speaking at one of Presbymania meetings in the past. I'm not very sure, but I think that she was here. But she is the researcher dealing with the lens. We have the International Scientific Committee, which is chaired by Jorge Alio, and we have some other members of this committee, including Pablo Altal, Sunil Shah, George Bejko, and others, and a whole list of Polish professors and doctors interested in presbyopia in our local national committee, including Professor Grupa Kominek, who is not here, but she is also a member of our scientific committee, of course. And we plan to launch an internet platform this year in Poland, which will deliver the reliable and broad information about different approaches to presbyopia, of presbyopia correction to patients and to doctors. And as you see, we will have a section, of course it is in Polish, because this platform will be for Polish citizens, obviously. So we will have a section, patient section, and then a section for a doctor, because we still see that many doctors, at least in Poland, they do not know much about different presbyopia, the strategies, what we can propose the patient, what can be done. And finally, we have also a section for our club members, which is after login, you can get that. So this will be available soon, in just a few months. We will do that. Yeah. So thank you very much for your attention.
Thank you.
We just go straight through to Andrzej, the second paper he has, which is scheduled the program for 3 o'clock. So in some ways we are ahead of time. We're just getting the next presentation together, which is what we have on the screen now.
Me or?
Yeah.
You are the second.
Yeah, continue it. You can charge.
Okay. So this is about the infections and how to avoid endophthalmitis in presbyopic refractive surgery. So finally, it is how to prevent endophthalmitis in intraocular surgery, like cataract surgery. Here again, my disclosures, none of them is relevant to the topic. And yeah, let me start with the short review of different sources of infection in postoperative endophthalmitis. It is well known that the main source is the patient's own ocular surface flora, and 60 to 80% cases bacterial isolates come from patient's own ocular surface. So we should be very cautious about any source of infection, blepharitis, nasolacrimal obstruction, so on. Then another source may be contaminated surgical instruments and surgical complications, very important risk factor for endophthalmitis. As we all know, posterior capsule rupture with vitreous loss increase the risk of endophthalmitis at least 10 times or even higher. So, okay. And another factor, very important, it's poor or delayed wound healing. So the appropriate architecture of the incision is crucial. It's very important. Just to support this, I will show you the study, which is quite old. It was published in 2005. It was based on 15,000 surgeries, and they found that this, the single biggest relative risk for endophthalmitis was a leaking wound on the first post-operative day, and the risk was 44. In this group, as high as 44 times high. So the authors concluded that this is the single most important thing we do to prevent endophthalmitis as a surgeon, is to make sure that our incision will not leak. When we are sure about it, probably we don't need to use antibiotic after surgery. There is some controversy regarding scleral versus conial incision. There were some studies, like this study from 2003, showing that the scleral incision was nearly 5 times less likely to have endophthalmitis than a conial incision alone. And as you remember, ECRS study, the only prospective study done so far, also confirmed that scleral incision is safer than the conial incision. However, finally today we use conial incision, and probably I don't think that we, at least only in some cases we can move into scleral incision. So there is still a field of controversy how it is really important issue. But just to mention that it was shown in several studies. There is a worldwide controversy between topicalists, that we say, so people who favor the use of topical antibiotics, and they don't use intracamurals, and intracameralists, people who use both intracameral and usually also topical antibiotics. Besides 2 countries, only in 2 countries they use only intracameral antibiotics. It's Sweden and Denmark. They don't use preoperative and postoperative topical antibiotics at all as a standard. So they use only intracameral. But generally, apart from these 2 examples, when people use intracameral, they also use it postoperatively topical antibiotic. Okay, this is our study we did, and finally we published it last year. It was an overview of current practices in endophthalmitis prevention in different parts of the world, as you see. We included 12 countries: Canada, United States, Mexico, Argentina, South Africa, Australia, New Zealand, Indonesia, India, Japan, China, Russia, and Sweden. And what we found, of course, I will show you just a part of the study, just a conclusion. So when we compare these different areas of the world, we found that endophthalmitis rate was similar, for example, in Japan, where they don't use intracameral antibiotics. Japan is here. For example, endophthalmitis rate in Japan was 0.05%. And after our publication, they even reported endophthalmitis rate of 0.02% last year. Very low. Very low, and they don't use intracameral. Also in China, they don't use intracameral. In Canada, majority don't use intracameral. In India, so what we found that the endophthalmitis rate was quite similar to the countries where they use intracameral. So there must be some other factors that only the use of intracameral or not using it. That is the major conclusion. Okay, so what are the what are the other problems, let me say? So in Europe, as you know, after ECRS study, using intracameral antibiotic at the end of the surgery became popular and common, and in many countries was included into the national guidelines and is treated as a standard of care. in majority of European Union countries. However, we have still many problems and questions which are unanswered regarding intracameral antibiotic. This is a table just to recall ECRS study, 2007. It was the only so far prospective randomized study showing the effect of intracameral antibiotics. And this study showed 5-fold reduction when intracameral antibiotics were used of endophthalmitis risk. This study showed. Okay. After that, there were many retrospective studies based on different antibiotics, as you see, not only cefuroxime, because of course ECRS study was based on cefuroxime. Then there were studies based on cefazolin, some studies based on moxifloxacin, and some studies even based on vancomycin, which are not shown here, but they were also. And by the way, vancomycin for many years was commonly used in US, very commonly used by many doctors. Okay, here is another table showing. Okay, but yeah, what do we know about cefuroxime? Cefuroxime is certainly best studied intracameral antibiotic. The only RCT study and majority of retrospective case series were based on cefuroxime intracameral use. However, there are certain important limitations of cefuroxime. For example, its relative and complete lack of activity against coagulase negative staphylococci and enterococci. And as you might know, in Sweden, they have the national register for cataract surgery and endophthalmitis cases. So they evidence every endophthalmitis case in Sweden. So they have a very good follow-up of cases. And they notice in recent years, the increase of enterococci endophthalmitis because of the use of cefuroxime. So what they started doing because of that, they started adding ampicillin. And this is the practice at the same day bilateral surgery now in Sweden is to add ampicillin to the cefuroxime because of its activity against enterococci. So this is the problem now in Europe. So we have a safe antibiotic. However, it's not as efficient. It has a relatively, it's not covering all microorganisms. And finally, there are reports showing endophthalmitis cases despite intracameral antibiotic prophylaxis with licensed cefuroxime. This is the publication from 2016, and there were 5 cases of endophthalmitis after the use of intracameral cefuroxime, leading to very poor visual results, including enucleation of the eye, no light perception, and so on. So it shows that it does not give us full protection. This is the problem. Of course, vancomycin, we know vancomycin, very potent antibiotic against this already mentioned microorganism, most other gram-positive bacteria. For many years, very commonly used in US by 50% of American surgeons. However, there were specific concerns against that. Its use was discouraged because, as we know, when we have endophthalmitis case, we use vancomycin to treat endophthalmitis. So overusing of the antibiotic in the prevention might lead to its, let's say, that we will lose its activity finally. So this was one of the concerns. And the recent concern, there were about 36 cases reported in the literature, cases of post-operative hemorrhagic occlusive vasculitis associated with intracameral vancomycin. Here we see one of these publications from Ophthalmology Journal. So both societies, American Society for Retinal Surgery and American Society for Cataract Refractive Surgery, they provided a clinical alert regarding the use of intracameral vancomycin, saying each surgeon should weigh up the potential risk of using vancomycin during surgery themselves and point out cefuroxime and moxifloxacin as suitable alternatives. So this is the problem with vancomycin today. And last but not least, moxifloxacin. It has certainly broader spectrum of efficacy than cefuroxime. Its intracameral use was shown to decrease the rate of endophthalmitis. However, the data from the Swedish National Cataract Register show no advantage with moxifloxacin compared to cefuroxime, and it is used on off-label basis. In Europe, I need to add, we have on-label medicine, which is called Iprocam. This is cefuroxime. That's make it much easier to use because of the legal issues. Moxifloxacin must be used on off-label basis all over the world. So finally, we have several dilemmas. What is better, intracameral versus topical? And if we decide to use intracameral, which intracameral antibiotic should be used? So, but what we know, there are questions we do not have answers yet, but here is the substance. We are completely sure that it gives us a great protection against many, against also endophthalmitis, but against different microorganisms. It's a povidone iodine, which was developed in the 50s, marketed as a 5%, 10% solution, and this is the only technique to reach category 2 evidence in reducing endophthalmite rates. Povidone iodine exhibit potent bactericidal effect upon contact for 15 to 60 seconds, and this microbiocidal, it is microbiocidal against multi-drug resistant bacteria, Candida species, viruses, and Acantharia amoeba, as well as capable of destroying biofilms. So its effectiveness is much broader than any antibiotic. Here we see the comparison between antibiotics, fluoroquinolins, in the upper row to povidone iodine, and you see that both cover gram-positive, gram-negative bacteria, but only povidone iodine is active against resistant bacteria, fungi, viruses, Acantharia amoeba. Effective concentrations of povidone iodine been reported to range between very low, as you see, 0.005 to 10%, and it's cheap, it's available worldwide, and this absent of drug resistance. There was a study testing if it is possible for bacteria to develop resistance against povidone iodine, and it's shown that there is no resistance. So it's completely safe. We can overuse it safely. It's another problem with antibiotics, that when we overuse antibiotics, we will lead to the antibiotic resistance. The interesting topic is that the active part of povidone iodine is free iodine, and the free iodine concentration, as you see on the graph, is highest in the concentration of povidone iodine between 0.01 to 1%. So paradoxically, higher concentrations like 5 to 10% does not necessarily are related with the highest free iodine concentration. So we could also, the lower concentrations, as you see in this table, like 0.25%, can be, because they have much more free iodine, it is shown here in the table, 20 ppm versus 5 to 10 ppm in high concentration. However, the problem with this lower concentration is that this is short lasting. So it needs to be repeated by washing every 20 to 30 seconds. This is the study which showed the role of the povidone iodine. It was published some years ago, 2015, from Munich, from Germany, and they shown that just by changing the practice pattern based on related to the povidone iodine use. Before, they used just 1 drop of povidone iodine, and then they started irrigating with povidone iodine, copious irrigation with povidone iodine. Just by this simple change, they decrease statistically significantly the rate of endophthalmitis. It shows how it is important that we use povidone iodine. And then I would like to show you another recent study, was published last year in the American Journal of Ophthalmology, showing they compared the effectiveness of povidone iodine 0.25%, so as you see lower concentration than 5% that we usually use, to topical antibiotics for treatment of bacterial keratitis. It's very interesting, and they shown that there was a similar effectiveness. So it shows the future for the povidone iodine use, that it can be even used not only in the prevention but also in the treatment of some infections. This is our recent article about the use of antiseptics in favor more than antibiotics. And this is our recent book. I would like to show you. It was published just two months ago on endophthalmitis with colleagues from Bascom Palmer. And in the conclusions, so the mandatory practice patterns to prevent post-operative endophthalmitis include careful preoperative patient selection examination, the use of povidone iodine, and of course perfect surgery. Wound architecture, no complications. Then recommended practice pattern to prevent post-operative endophthalmitis include intracameral antibiotic. However, there is a still ongoing debate on the perfect antibiotic, and it was shown that it gives you a protection when you have relatively high endophthalmitis rate. When this is endophthalmitis rate of higher than 0.1%. And the practice of low value, I did not discuss that, but it's probably preoperative topical antibiotics when intracameral antibiotics are used. Many countries now avoid, or many people also in France, for example, in the national guidelines, it is disrecommended to use preoperative topical antibiotics. In Poland, we also in our guidelines inform that there is no evidence for using preoperative topical antibiotics when intracameral antibiotic is used. So many surgeons stop using preoperative antibiotics. So this is again presbyopia, and I organized a course. This is, by the way, the list of my courses this year in American Academy. And one of the courses is on, this is on the myopia. We discussed yesterday myopia, but one of the courses is on post-operative endophthalmitis. So if you are at the American Academy, I would be more than happy if you come to this course and support the discussion about it. We have a very good faculty, Randall also, Nick Mamalis, Tara Prasad Das from India, and Tatkal Chen from Singapore. This is about different practice patterns around the world, update 2018 at American Academy this year. Thank you very much for your attention.